This is really the first day of the San Antonio Breast Cancer Symposium. This morning in the general session, we heard several very interesting and important presentations. There was a group of papers that addressed the use of immuno-oncology, specifically immune checkpoint inhibitors, in the treatment of primary HR-positive, HER2-negative, and triple-negative breast cancers. And in the HR-positive, HER2-negative breast cancers, the papers presented suggested that contrary to our previous assessment of immuno-oncology in that group of patients, there is indeed some early benefit for the addition of immune checkpoint inhibitors, and that is a new development and a very important development. In the triple-negative breast cancer group, the current results actually suggested that the timing of immune checkpoint inhibitors in primary breast cancer is very important, and that the optimal time of administering immune checkpoint inhibitors is before any other treatment, certainly before surgery in the neoadjuvant setting, and that waiting until after surgical resection might abrogate the benefit of immune checkpoint inhibitors. This is very important because the sequence of treatments in breast cancer is very important. So that was an important group of papers. There were several papers that tried to identify biomarkers. Biomarkers are the holy grail of what we do, because up until now and for the past 60 years, all new drug development was based on administering a drug to 100% of patients and finding out that that particular drug just benefited 10% or 20% or maybe 30%. Unfortunately, to date, we have had limited success. And in the case of CDK4/6 inhibitors, we have not found a reliable and reproducible biomarker. So we will, for the time being and until such a biomarker is identified, we will continue to expose all patients to the benefit of this agent. We also saw the final overall survival results of the MONARCH-E trial in metastatic breast cancer. The MONARCH-E trial was a Phase III randomized trial in first-line metastatic HR-positive, HER2-negative breast cancer, in which patients received standard endocrine therapy, and half of them were randomly assigned to abemaciclib. We have been awaiting these results for several years. The drug has produced a significant prolongation of progression-free survival, like the other CDK4/6 inhibitors. But even with a much longer follow-up, the final overall survival analysis showed that while there was a numerical prolongation of overall survival, that did not reach statistical significance. And this comes in the wake of another trial with abemaciclib in second and third line therapy of metastatic breast cancer, in which the same observation was made: a numerical prolongation of overall survival, but not quite reaching statistical significance. So at this point, we have, of the three aromatase inhibitors, we have palbociclib, which has three randomized trials in metastatic disease and two randomized trials in the adjuvant setting, which are all negative in terms of overall survival. We have the two metastatic trials for abemaciclib, which show significant progression-free survival prolongation and numerical improvement in survival that does not reach statistical significance in either trial. And then we have the MONARCH-E trial in the adjuvant setting that shows a significant prolongation of IDFS and is still immature to assess overall survival. So that's the status of the field, but I think these trials have had a major impact in how we look at CDK4/6 inhibitors. Had you asked me this question 3 years ago, I would have told you that the three CDK4/6 inhibitors were practically interchangeable, that they were very similar in outcomes, and they had some minor differences in safety profile. Today, I have to tell you that that is completely not true, that palbociclib is probably a less effective agent, and therefore our group has stopped considering it as one of the options. That abemaciclib is an important drug. Perhaps some of the trials were not large enough to detect with statistical significance the impact of its benefit, and that ribociclib at this point seems to be the standard of care for the patients in the metastatic setting. And it certainly is producing significant benefits in the adjuvant setting at an early stage in follow-up.